Hello everyone, happy evening, a very good evening. I hope now I am audible and visible. Please say yes that now I'm audible and visible. Let me check as well. Yes, yes. Okay, that's great. So there was some glitch and thankfully it's resolved. So happy evening everyone, a very good evening. I hope and I believe all of you are doing well and I hope you are following the daily targets very well. Right? So, for someone who's new here, we are following a daily timetable basically. I share the daily targets on the Telegram group, which is Dr. Nikita's Radsynapse. And apart from that, an update also about the offline short 150 class for the upcoming FMGE exam, which is going to be in Delhi from 10th to 12th of July. So all the FMG students, please make the best of this opportunity because we are going to learn all 19 subjects are high yield points and I'll try to help you get that 150 score. So with the hope that you'll be done with your entire syllabus, like at least one read by then. And to consolidate everything in 3 days, we are going to do that. Can the NEET PG students attend that? It's an offline event. Yes, the NEET PG students who have started their preparation now, who want to learn all the mnemonics, that I keep talking about, the tricks, you want to know how to prepare for the exam, you'll get a very good idea about the same from this session. So you can attend it as well. Though we will have a NEET PG session like revision sort of thing before the NEET PG, the next NEET PG comes. Okay. Okay. Hi, Ananta. Everybody here, namaste, happy evening, whatever you want to say it. So today here we are to discuss the top 20 mnemonics in orthopedics. Why orthopedics? Because in our daily targets, like I said, the timetable that we are following, we have started with the subject of orthopedics today, and in our daily target for today, we have the general part of it and the upper limb part of it. So basically, to help you in that, right, to have a session where you feel that you are doing the daily targets as well. Okay, so that's the reason that we are doing this. Okay, paras to nahi aa sakte unke liye online I am working on it. I'll also give you an update on that very soon. Okay, so I'm planning to do it online as well. No, it's been I've been here regularly, Dr. Yashraj. I think you have not been there. Okay, so let's start with the mnemonics for today, the top 20 mnemonics in the general and the upper limb orthopedics. And I've shared the PDF already on the Telegram group. So if you want to make the notes as we discussed, you can do that as well. The PDF link is also in the description of this video. So you can also go to the link and download the PDF and make notes as we discuss. So starting with the first one that we have, so upper limb and the general part of orthopedics. So the Cockers or the Kochers technique, whatever you want to call it, is for anterior shoulder dislocation. Reduction technique is Kochers technique. And the question is, this is one of the AIIMS exam question. What is the sequence? How do you do? Is what are the steps in the Kochers technique? So remember that this can come as an I9CT question also, arranged in sequence, the step in the Kochers technique. So the mnemonic for that is team. Right, the mnemonic for that is team. That is traction, external rotation, medial rotation. But this is where the confusion will arise, whether it is adduction or it is abduction. Okay, so that's why the mnemonic here, remember, it is steady me or steady me. Okay, you can read it as steady me. So when there is dislocation, the person becomes theta. So remember, it is steady me when there is anterior shoulder dislocation. So what does that stand for? That basically stands for traction, external rotation. The AD tells you that it is adduction and not abduction. It is adduction and then we have the medial rotation. So remember that it is adduction. So with the dislocation, it is steady me. So that is adduction. Very, very important. Okay, so remember that it is adduction. Because anyways, we know that in the anterior shoulder dislocation, what is the limb position? We have Faber, right? We have Faber which is there. So that is why we'll be doing the adduction. So going on to the next question here. What test do you think is this? This is also the question asked in the recent, not one of the, in the recent NICT exam, May 23 exam. This was the question, the image which was also asked there. So what test is this? Where basically you are testing for the patency of the ulnar artery, the radial artery, right? First you block both of the arteries by giving the pressure, then you release one, and you look for the palm becoming red. This is called as Allen test. Okay, this is called as Allen test, and you can remember it as Allen is basically, so you are checking for all is well. Right. So the Allen test is basically when Allen is all is well. All is well. That means the circulation is all good. There is no blockage of the artery. So this is done basically before putting the AV fistula, before doing the fistula in a patient who's a renal failure patient who's about to start on dialysis. So we do the AV fistula. So we have to be sure that the circulation is adequate. So remember, this is the Allen test. Next mnemonic here, hanging cast or the U slab is used for which fracture? Hanging cast or the U slab is used for which fracture? Yes, anyone? For which fracture do we use it? Very good. That is basically used for humerus fracture. Okay, it is used for humerus fracture. So remember that humerus, when I write H and U, the H and U helps me to remember that it is the hanging cast or the U slab, which is basically used for humerus. So the H and the U, that is the hanging, and the U is basically for humerus, and this is where you can see this hanging cast. Okay, this is where you can see this hanging cast here. It is used for the humerus fracture. Okay, that's one mnemonic there. Going to the next one, NEET's classification is used for which fracture? Is it used for supracondylar humerus fracture? Is it used for shoulder dislocation? Is it used for proximal humerus fracture, distal humerus fracture, distal radius fracture? What is NEET's classification used for? Okay, I'm waiting for the answers here. So remember, NEET's classification is used for fracture of the proximal humerus. Okay, it is used for fracture of proximal humerus. How do we remember this as? Humerus basically is humerus. Okay, humerus, which is a humorous way of learning all the 19 subjects, is Nikita's Radsynapse, that is NEER. Okay, so Nikita's Radsynapse basically helps you remember all the 19 subjects in a humorous way. So remember, NEER is humorous, and if you read with those humorous tricks, you will get a proximal rank. That's a top rank. So basically it is proximal and not distal. That is what also you have to remember. Yes, very good, Sirisha. So you remember that. So Nikita's Radsynapse humorous mnemonics help you to get the proximal rank. Okay, so that is how you remember. NEET's classification has also been asked in the previous exam. Okay, that's important. Next one, Gustello-Anderson classification of fractures. What is the type 3 fracture? Remember 3, the third alphabet is C. So the type 3 is basically the comminuted fracture that we have. What is 3A, what is 3B, and what is 3C? So remember, in 3A, there is A for A is adequate coverage is present. In 3B, B for bone is exposed. That means a lot of soft tissue injury is there. The bone is exposed. And remember, C for circulation affected. That means there is arterial injury. Okay, that means there is arterial injury in C. So yes, it is comminuted open fracture. So remember that it is Gustello's may A is adequate. Then you have B, which is bone exposed, and C is circulation affected. That means there is arterial injury, right? So absolutely right. So if you have the bone exposed, the pulses are felt, it is 3B. If the pulses are absent, artery affected, the pulse will be absent, so that is going to be 3C. So B is bone, C is circulation, and A is adequate coverage is there. Going on to the next one, the Salter-Harris classification. So the mnemonic for Salter-Harris, the physeal injury basically is Salter itself. Okay, the mnemonic itself is Salter. What does Salter stands for? So the type 1 is a straight line through the physis. Right, through the physis plate itself, it's a straight line. A stands for above. That means the metaphysis is affected. L stands for lower level. That means it is going down. Okay, it is going down. T matlab through and through. That means above also and below also. So everything is involved in the type 4. And E matlab erased. What is erased? The physis is erased. Why? Because there is like a ramming or the crush type, the compression of the physeal plate. So the physeal plate is closed. So remember that is this is basically the Salter classification. That is S is straight. This is how you remember. Basically, I hope this is easy to remember now. S is straight, A is above, L is lower, T is through and through, and ER is eraser. Okay, that is the crushing or the compression of the growth plate. So you don't see the physeal plate here. So you can get an image-based question and you might be asked to identify the type of Salter-Harris fracture that you are seeing here. So ER is erased. Okay, that's an erased physis plate. Next one, this is a previously asked question. So what are the tests in the thoracic outlet syndrome? What are the provocative tests in the thoracic outlet syndrome? So remember, the provocative tests are the war. Okay, so it is on a war. So in thoracic outlet, remember there is a war going on. So imagine the provocative test is war, that is the Wright's test, the AIIMS test and the Roos test. And this is a previously asked image-based question in one of the AIIMS exam. Identify this test which is shown here. So this test, whether it is Wright's, it is AIIMS or it is Roos. So remember this test that you have where the person is taking the hands up. This is the Roos test. Okay, this is a Roos is like a booth. Okay, Roos is like a booth. So I put that image of booth also there with the hands up to help you remember that Roos is like a booth position. You are trying to scare someone. Booth banke. So Roos is like a booth, and Roos is also called as the East test. What does the East stand for? Elevated arm stress test. Okay, it is elevated arm stress test. So with the arm elevated, you ask the patient to open and close the fist for at least 3 minutes. And if there is pain, there is tingling, that means the test is positive. Okay, so remember that we have these tests for the thoracic outlet syndrome. And some other important points for thoracic outlet syndrome. Remember the causes like cervical rib is one of the important causes. And what trunk of the brachial plexus is affected? What trunk of the brachial plexus is affected by the thoracic outlet? Is it the upper, is it the middle, or is it the lower trunk? It is the lower trunk. Okay, remember it's the lower trunk. So I hope you remember from anatomy C5, 6, 7, 8, T1. The 5 fingers of the upper limb, the brachial plexus starts with C5 and you have 5 roots. First 2, last 2 and you have Beachwala. So the lower trunk is basically C8, T1. Okay, so it is C8, T1 which is affected. So tell me that if C8T1 is affected, there will be tingling numbness along what aspect? The C8T1 is basically the medial aspect. Okay, the medial aspect of the upper limb. What nerve is the C8T1? It is the ulnar nerve which will be compressed. Okay, the ulnar nerve which is getting affected. Because I hope you remember the mnemonics from anatomy. 3 long musketeers assassinated 5 rats, 5 mice and 2 unicorn. The last 2 unicorn, that is C8 and T1, unicorn is the ulnar nerve. So C8, T1 is the ulnar nerve. Right, so all these are the important points. Remember, the lower trunk is affected, C8, T1, ulnar nerve, it is the medial aspect which is affected. And cervical rib is an important cause of thoracic outlet syndrome. Okay. Going on to the next one, tennis elbow is which epicondylitis? Is it the lateral or is it the medial? And what test do we do for the tennis elbow? Yes, tennis elbow is what epicondyle affected? Medial nahi. It is lateral. Remember, tennis is TE. Okay, tennis is TE. So the tennis elbow is the lateral epicondyle affected, and lateral epicondyle basically is the common extensor origin. Okay, it is the common extensor origin. Extensor, which extensor muscle is commonly affected? It is extensor carpi radialis brevis. ECRB is commonly affected in the tennis elbow. And what is the test for the tennis elbow? The test is, imagine you are playing a tennis with your cousin. That is the Cousins test. Playing tennis with the cousin, that is the Cousins test, is done for the tennis elbow. The reverse Cousin test is for the medial epicondyle, that is golfers. Okay, that is golfers. So look at this one. This is the image which is showing the Cousins test, where we are trying to look for the tenderness at the lateral epicondyle with the extension against the resistance. Okay, with the extension against the resistance, there will be tenderness at the lateral epicondyle. So versus, remember that the medial one is the golfer's elbow. So opposite golfers is medial, and we have the reverse Cousins test for the golfer's elbow. Okay. Next one. So look at this image, and it's already mentioned that it is mallet finger. So in mallet finger, what tendon is getting ruptured? Is it the extensor tendon or is it the flexor tendon? So this you can remember, mallet is like mallext. Okay, mallet is like mallext. That means what is malfunctioning? It is the extensor tendon which is malfunctioning. So mallext is basically malfunctioning of the extensor tendon. So if the extensor tendon is gone, the finger will be in the flexion position. Okay, the finger will be in the flexion position. Why this is not the swan neck deformity? Why this is not the swan neck deformity? Because remember, these arthritis, like rheumatoid arthritis, is where we see the swan neck deformity. There are two joints which are affected in trauma, that is mallet finger or jersey finger. It is one joint which is affected. So here in swan neck, so imagine doing the swan neck like this. So what happens is there is DIP flexion plus there is PIP hyperextension. There are two joints, दोनों joint पे कुछ ना कुछ हो रहा है. Okay. While in the trauma, it is just one tendon or one joint which is affected. So this is the avulsed tendon which is gone here. Okay, so this is mallex. Versus where you have the flexion which is affected, that is the jersey finger. In the jersey, it is the flexion which is affected. The flexor tendon is gone. So if the extensor tendon is gone, the DIP remains in the flexed position. So that is mallet finger. Okay, that is mallet finger. So the question asked in one of the previous AIIMS exam is, if you are putting a splint for mallet finger, how will you put the splint in the mallet finger? Because the extension is gone. So it is the splint has to do the function of that. The splint will be put in extension because the extension is gone. So the splint will do the function of the affected muscle, that is the extension. Right? Clear with everyone? Let's go to the next one now. What are the tests for the anterior shoulder dislocation? Vishnu, what's the doubt in the Cousins test? Cousin is tennis elbow, lateral elbow, common extensor. So you ask the patient to do the extension against resistance. That is what is Cousins test. Now the trick for the test for the anterior shoulder dislocation. So anterior dislocation, the tests are A, B, C, D, and then you have H. The B is the Bryan's test. C is the, what is the C test? C is the call-away test. D is the Dugas test. And H is the Hamilton ruler test. Okay, H is the Hamilton ruler test. So these are the tests that we do for anterior shoulder dislocation. So you have A, B, C, D, anterior ke liye Bryan's, call-aways, Dugas, and you have the Hamilton ruler test. Now look at the first image. What is this test here? Out of the 4 tests that we spoke about, what test is this? What test is this one? Yes, this one is not the call-aways test. I'll tell you the trick to remember these tests as well. So this test is this test is Bryan's test. Okay, this test is the Bryan's test. So remember B for below. Okay, below, that means the axillary fold is at lower level in the dislocated shoulder. So look at, normally it should be at the same level. Here this is at a below level. Okay, it's at a below level. So this is Bryan's. So Bryan's is below. Bryan's is below. Okay, Dr. Manasvi. This one, the circumference wala is this. Where you are taking this circle around, you are measuring the circumference. So remember C for C. Increase the circumference of the axilla, C for C. That is the call-aways test. So in the call-aways test, the circumference is increased. C for C. This one, where you see that obviously the ruler is being used here. Normally the acromion does not touch the ruler. So obviously this is the ruler test. That is the Hamilton ruler test. And this one, where you ask the patient to touch the opposite shoulder, that is the Dugas test. That is painful and the patient might not be able to do it. So remember, Dugas is basically dusre jagah pe going. Okay, going to the dusra shoulder, that is Dugas. Okay, dusra going. So when the patient is trying to touch the opposite shoulder, that is the Dugas test, right? So I hope everybody is clear. Bryan's is below, C call-aways is circumference, Hamilton is ruler, and you have the Dugas test. Okay, and you have the Dugas test. So these are the various tests for the anterior shoulder dislocation. Next one, very important, very important. Dermatomes is an important topic. What is the dermatome for the palmar pad of the thumb? Is it C4, C5, C6, C7, C8? What is for the palmar pad of the thumb? Okay, Chandani, that's not C8. Very good, Amit, Dr. Manasvi, Mohit, everyone. It is C6. Now, how do you remember that the thumb dermatome is the C6? So, make like this. Okay, keep the thumb up, make a fist, and look at this number here. Okay, so when you are making it with the thumb and look at the hand, so basically the thumb with the rest of the fingers, that makes your number 6. Okay, this is like a number 6. So this is C6. Okay, this is C6. Or you can also remember it as thumb sucks, right? Thumb sucking. That is thumb sucks is 6. That is C6. So remember, the thumb is the C6. Then you have this C7, the index finger. The little finger is the C8. Okay, the little finger is the C8. Thumb is C6. Very important. Going on to the next one, Milch classification is used for which fracture? Milch classification is used for which fracture? Right. So easy trick to remember that is, remember Milch is LCH. Okay, Milch is LCH. So Milch classification is used for LCH, that is lateral condyle humerus fracture. Okay, that is lateral condyle humerus fracture is the Milch classification. Okay, very good, Paras. So that is LCH. Milch is lateral condyle humerus. Okay, lateral condyle humerus. Okay. Going on to the upper limb nerve injury test. So remember, very, very important. You'll get a question on this in your exam for sure. Ulnar, you write it as alphabetically A, B, C, D, E, F are the test. So remember, A is for ulnar nerve. The tests are the book test, the card test. The D and E basically is for dorsal interossei. We have the E test, which is the Igawa's test, and F is the Frommans. Okay, F is the Frommans. So remember that for ulnar nerve, it is a book test, the card test. For dorsal interossei, it is Igawa's, and F is for Frommans. So in the book test, tell me the muscle which is being tested. This is your recent INICT exam question. So this is important. In the book test, when you ask the patient to hold the book, so basically what action of the thumb is happening? It is adduction. So which pollicis muscle is supplied by the ulnar nerve? Very, very important. It is the adductor pollicis. So if the patient is not able to hold the book, then it is the Frommans sign, which is positive there. The adductor pollicis is replaced by the flexor pollicis. Card test. When you ask the patient to hold the card in between the fingers and you try to remove that, it is the adduction of the fingers. The adduction of the fingers is by palmar interossei, PAD. Okay, so basically the card test is for palmar interossei. Yesterday in the class we saw about the interossei. All interossei are anterossei. That means they are supplied by the ulnar nerve. So dorsal interossei, palmar interossei, all of these are supplied by ulnar nerve. So for dorsal interossei, it is the Igawa test, and Frommans is your book. Right? So these are the tests for the ulnar nerve. What are the tests for the median nerve? So remember, for median nerve, M के बाद ulnar के लिए A, B, C, D, E, F. For the median nerve, it is MNOP. What is MNOP? So for the median nerve, we have the Nevin sign, the Kilonevin sign, O for the Ochsner's clasp. Okay, the O for the Ochsner's clasp. And we have multiple P's for the median nerve. That is the pointing index. Okay, so what do we have for the median nerve is the pointing index. Then we have the Pope's benediction. Okay, the Pope's benediction hand. And we have the ape thumb or the ape hand deformity. So all the P, and also the most important, remember, is the pen test. Do not forget that. It is your recent NEET PG exam question as well. So remember that it is the pen test, the pointing index, the Pope's benediction, and the ape thumb, which is for the median nerve. You have the Ochsner's clasp. In the Ochsner's clasp करेंगे ऐसे तो pointing index आएगा. That is the pointing index. Okay, that's the pointing index. So remember that all these are the median nerve test. Okay, these are the median nerve test. Going to the next one, chiralgia paresthetica is basically compression of which nerve? Chiralgia paresthetica, and you have meralgia paresthetica. Chiralgia and meralgia. What is chiralgia paresthetica? A compression of? Right. So I have marked this here, the RAL. So chiralgia, meralgia is basically the radial nerve. So remember, this is the RA is the radial nerve. The superficial branch of the radial nerve is chiralgia. Okay. And meralgia, RAL. So remember, L for lateral. Meralgia is in the lower limb, in the thigh. The lateral cutaneous nerve of thigh. Do you remember, if you integrate this with obstetrics, which maneuver do we talk about which can cause this meralgia paresthetica? Which maneuver can cause this meralgia paresthetica? The lateral cutaneous nerve of thigh. It is the Mac-Roberts maneuver. It is the Mac-Roberts maneuver. which is done for shoulder dystocia. Okay, which is done for shoulder dystocia, the lateral cutaneous nerve of thigh, which was also asked in the recent NEET PG exam, the laparoscopic hernia surgery. In that also, in the mesh encrepment, the lateral cutaneous nerve get affected. That is meralgia. So remember the radial and the lateral. Okay, it's the radial and the lateral which is affected in both of them. Yes, very good. Going on to the next one. Coming to some other nerve compression syndromes. In the Guyon's canal, in the cubital tunnel syndrome, what nerve is affected? Cubital tunnel versus carpal tunnel. What nerve is affected in these ones? So remember, the Guyon's canal is the U, that is the ulnar nerve. The cubital tunnel is the U. So remember, both of them is ulnar nerve. Okay, both of them is ulnar nerve. Guyon's, cubital, both of them is ulnar. Pronator teres, remember the P was for the M. So M is the median nerve. Okay, we had this question in the yesterday's anatomy test as well that we discussed yesterday. So pronator teres, PP is for the median nerve. The median nerve goes in between the two heads of the pronator teres where it can get compressed. Okay, supinator wala, dorsal wala, the arcade of Frost, that is the radial nerve. Okay, that's a radial nerve. So remember, the PPP is for the median nerve. So even pronator teres is the median nerve. Carpal tunnel we all know is the median nerve. Okay, carpal tunnel we all know is the median nerve. So the difference between pronator teres and the carpal tunnel is, in pronator teres the sensation is also gone. In carpal tunnel the sensation on the thenar aspect, the palm sensation is not gone. Okay, that's the difference in between the two. Going on to the next one, the Galeazzi versus the Monteggia fracture. So remember, the mnemonic for this is Murga. What is Murga? Murga is Monteggia is ulnar fracture, radius fracture is Galeazzi. So MURGA. Monteggia is ulnar fracture, radius fracture is Galeazzi. Okay, so very, very important. And remember, this is not the distal radius fracture, this is the radius shaft fracture. Along with the dislocation of which joint? What dislocation do you have in the Monteggia? So when I write Monteggia and when I write Galeazzi, so remember, in Monteggia it ends with A. In Galeazzi, Galeazzi has Z. So when I say alphabets, A is proximal, so it is the proximal radioulnar joint dislocation which is happening. At the proximal radioulnar joint, we have the radius head. So that is why it is a radius head dislocation. Galeazzi is Z, that is distal radioulnar joint. Okay, it is distal radioulnar joint dislocation. So you get this question also very frequently. Monteggia is radius fracture with proximal dislocation, ulnar fracture with proximal dislocation. That is what you should know. Now coming to the images. So this image, what fracture are you seeing? It is the wider bone which is fractured. So this is the radius, and this bone which is thinner one is the ulna. So that is why this is a radius shaft fracture. So I think of Galeazzi. Look at the Galeazzi. Z is the distal one. So the distal radioulnar joint which is affected there. Right. So that's why this is Galeazzi fracture, where you see the radius shaft is fractured with the distal radioulnar joint dislocation. This is Galeazzi fracture. Okay, this is Galeazzi. This one here is the ulna. How do I know this is ulna? By the olecranon process. So this is ulna, this is radius. So you can see this is ulna fractured with the radius head which has gone out of its position. So Monteggia is ulna fracture with proximal. So this is Monteggia fracture. Okay, this is Monteggia fracture. Next one, coming to the Colles versus Smith. Which one has dorsal displacement? Which one has volar displacement? So remember, Colles A, B, C, D. Okay, that is A, B, C, D. And you have S ke baaju mein alphabetically you have V. So in Colles it is dorsal displacement. In Smith it is volar displacement. Right. Now, how do you identify whether this is Colles or this is Smith? Tell me, what do you think is this one? Nightstick fracture, Shweta, is the isolated ulnar fracture without any dislocation. That is nightstick fracture. Is this Smith or is this Colles? What do you think? This image that I'm showing you, is this Coley's, is it Smith, is it Barton's, is it Bennett's? This is not Coley's, guys. Okay, this is not Coley's. This is a Smith fracture. Yes, Aarti. So look at this. There is distal radius fracture. So that is why I think of Coley's or Smith. It is extra articular, not involving the articular surface. This is distal one. Look at the displacement, the distal fragment displaced. You can see that the angulation is like this. How do I know this is the Palmer aspect? One thing is, you can look at the thumb ka position. Look at this thumb ka position. The thumb cannot extend a lot. You know, इतना ज़्यादा extension नहीं होगा thumb का, but flexion अच्छा खासा होता है. Extension बहुत ज़्यादा नहीं होगा. Second, look at the concavity. Okay, the metacarpals. If you look at the palm, it is a bit concave, right? So the concavity of the metacarpals, and also look at the soft tissue. Where do you have a lot of soft tissue? The muscles, these are in the palmar aspect. The dorsum is where you don't have a lot of muscles. So this is dorsal, this is palmar, that is volar, and the fragment is going towards this side. So this tells me that this is the volar displacement, volar angulation. So this is going to be Smith fracture. I hope this is clear with everyone. So the concavity, the soft tissue thickness, the thumb, that is telling me that this is volar, this is Smith. Now, look at this one. Where do you see the angulation now? First of all, this is a distal radius fracture, which is extra articular, right? Now, look at the angulation. Where is it angulated? It is angulated towards less soft tissue aspect, okay? It is not towards the concavity. This is the dorsal aspect. This is the volar aspect. So, this is dorsal. So this is Coley's. Am I audible and visible? Why am I not seeing the live chat suddenly? Just give me a minute. Let me see whether it's only on my end. I don't know. Yes. Okay. So this is Coley's and Smith. And what fracture is this one here? Wait. What fracture is this one here? So this fracture, you can see, is a distal radius fracture, but along with this, you can see a break in the articular surface also. There's a break here, right? So there's some the fracture line is going to the articular surface there, and that is why this is the intra-articular fracture of the distal radius. So remember, the intra-articular fracture is the Barton's fracture. Barton's is intra-articular, ART. That means it involves the articular surface. So that is why this is Barton's. Schoffer's is only the styloid process. Okay, so this is not Schoffer's. So these are the distal radial fractures. I hope this is clear. CD, Coley's, dorsal, SV, and Barton's is articular. Okay, Barton's is articular. Going on to the next one that we have here, and please do not confuse Barton's with Bennett's. One more point to be added here. Do not confuse Barton's with Bennett's. Remember, Bennett's is double T, that is TT wala. It is the thumb base fracture, and it's a B is bi. That means that it is two segments. Okay, two bones, two fragments that you have in the Bennett's, versus Rolando, which is comminuted one. It is inverted Y shape, is Rolando's fracture. Okay, that is Rolando's fracture. Next one, coming to the last point here, some important points about the carpal bones. Which is the first carpal bone to ossify and the largest? So remember the head. Who is the head of the carpal bones? Who comes first? And sabse bada. It is the head of the family. Head pe we wear the cap. So remember, it is capitate who is the head. So head is the cap. The first to ossify and the largest is the capitate. The last to ossify is pisiform at around 12 years. capitate comes at around 2 months. Okay, that is about 2 months post-natal. Which carpal bone has a hook? We talk about hook of HH, hook of hamate. Okay, it is hook of hamate. So if there is fracture of the hook of hamate, which nerve injury occurs? Which nerve injury occurs? It is ulnar nerve. Okay, so with the hook of hamate fracture, it is the ulnar nerve injury. Why? Because if you remember the sequence of the carpal bones, she looks too pretty, try to catch her. This is from the radial side to the ulnar side. So where is the hamate coming? The hamate is coming on the ulnar side. So remember, the hamate is the ulnar nerve. Okay, the hamate is the ulnar nerve. Kin box is the osteochondritis of which carpal bone? Kin box, again remember alphabetically H, I, J, K, L. So after K comes L, it is the osteochondritis of the lunate. Another important question related to lunate, when there is lunate dislocation, which nerve gets compressed, or which nerve can get affected? So remember that KLM. L के बाद आता है M. It is the median nerve. Okay, it is the median nerve. So remember that KLM, that is kin box, is lunate, is median nerve. Okay, lunate dislocation, that is the median nerve. Next one, this question has been asked in the previous FMGE exam also, very, very important. Which fracture, which carpal bone fracture can cause anatomical snuff box tenderness? So logically thinking, the anatomical snuff box is here towards the thumb, that is the radial side, and on the radial side, the carpal bone that we have is scaphoid, right? Towards the radial side, first one is the scaphoid. So that is the scaphoid fracture. Okay, fall on the outstretched hand, outstretched arm, that is the scaphoid fracture. And remember that the risk, the complication that can occur with the scaphoid fracture is avascular necrosis. Okay, it is avascular necrosis that can occur. What X-ray view do we prefer doing for scaphoid fracture? Oblique view में the scaphoid fracture is seen better. Okay, in the oblique view. So this is basically the important points about the carpal bones, right? So yes, that was about the today's top 20 mnemonics in the upper limb and the general part of orthopedics, where we have seen the Gustello-Anderson's classification, the Salter-Harris classification, and important points about your upper limb orthopedics. Okay? So yes, I hope guys you have enjoyed this session of our top 20 mnemonics, right? And if there is any other topic that you are struggling with or you want me to cover, please do let me know. Okay? Thank you so much everyone for joining in, and yes, goodbye, take care, and keep studying, keep revising, and keep winning. Thank you so much.